I'm Roger Baker, Executive Director of the Stratfor Center for Applied Geopolitics at RANE, a global center of excellence for geopolitical intelligence and analysis. Learn how you can put geopolitics to work for your organization at ranenetwork.com.
Welcome to the RANE Insights podcast from RANE Network. In this episode, founder of RANE, David Lawrence, sits down with Dr. Mark Gold for part 2 of their discussion on the United States of addiction, dealing with the opioid crisis in the medical community and beyond. Dr. Mark Gold is an author, inventor, mentor, and a world-renowned expert on addiction-related diseases. Dr. Gold has had over 1,000 peer-reviewed publications since beginning his academic career at the University of Florida College of Medicine and Yale University School of Medicine in the 1970s. Dr. Gold has modernized addiction and psychiatry training, fellowship and treatment programs, while hopeful that research would translate into new, more effective treatments. Check out Dr. Mark Gold's full bio and host of written publications at psychologytoday.com.
Mark, thanks again for joining us. Let's call it Chapter 2 in the United States of addiction, and it's great to be able to leverage your insights and expertise. You continue to be prolific in your writings, and I thought today we've heard from some members of our audience. I'd love to focus on some of the recent articles, and we'll post them as well, that you've written in Psychology Today about the fentanyl crisis. And maybe a good way to start is just to get your overview about the crisis and the implications. And I know you have some areas of focus that have not gained national attention. And you also have a variety of suggestions for how to respond. The one editorial comment, I don't know whether to feel a little bit better about things, but I'm hopeful, in contrast to prior presidential debates and campaigns, that maybe this issue will become front and center. It seems to be mentioned a little bit, but hopefully it will, gain some attention on the national stage. But let me just turn this over to you, and you've been following this, you've been involved with it for a good period of time. Just share some thoughts with us.
Sure. Well, thanks, David, and thanks for the listeners emailing and comments. If you looked at the deaths, and death rates have been the focus of attention. If you think about how we look at outcomes, like if you had an infection, we might look at a chest x-ray, or if you had a heart attack, we might look at cardiac enzymes. Sadly, in how we're doing in the substance use disorder field, most of the attention, if not all the attention, has been placed on deaths. And drug-related deaths claimed in 2022 about 108,000 people, according to the CDC. Now, just to put this in context, if you just Google how many drug deaths were there when naloxone was invented in 1971, was on the market thanks to the FDA, you'd say, my gosh, that barely 1,000 deaths some years, sometimes 1,500, all drug deaths put together. So this is just a huge number. Partly this is due to a seismic shift from plant-based drugs that the DEA was very good at interdicting, like heroin and cocaine, the shift from those to chemical synthesized drugs in laboratories like fentanyl and methamphetamine. So in the last opioid epidemic in the 70s, we had heroin from Southeast Asia, and we had cocaine from South America, and they would be transshipped, and a certain percent of them would be intercepted by the DEA, and that kept the prices up. Now we have laboratories all over the place and formulas and how to do it on the web, to how to make fentanyl and how to make methamphetamine. So the new speedball of our time is actually fentanyl plus methamphetamine. Fentanyl itself is responsible for most of the deaths. Some people say 80% of the deaths. So if the number one cause of drug deaths are opioids, that's predominantly fentanyl, which has replaced heroin. And if the number two is methamphetamine, still 30 or 40% of those methamphetamine deaths are actually due to fentanyl as well, partly because there's some adulteration, also because they're co-used, and thirdly, the sharing of pipes, etc. Sometimes there's a residue left behind. We also have these fake pills, which are sometimes adulterated with fentanyl, and that's the DEA's One Pill Can Kill campaign. Fentanyl itself is really deadly, and for people who are in criminal justice or remember this, the Russians aerosolized fentanyl and let it loose in the theater incident with the Chechen takeover of the theater to try to rescue the theater goers, and then found out, to their dismay, that they didn't have enough naloxone, Narcan, to reverse all the fentanyl overdoses. So that brings up fentanyl's chemical. It's easy to manufacture. It's adulterated in pills. We have deaths due to that. It's replaced heroin on the streets. We have lots and lots of deaths due to that. And it's also a potential bioweapon, if you will. Very little fentanyl is lethal. Our group actually showed that if you inject fentanyl intravenously, small amounts of it are actually exhaled in your own breath. Not enough to kill people smelling your breath, but significant enough to be monitored. So very small amounts of fentanyl can be lethal, and the amounts that people have in their drug is so small that rather than having disposable submarines or a cross-border huge trucks and so forth, fentanyl might even be shipped in the U.S. mail. Seizures of fentanyl are at record levels, but also now fentanyl is adulterated with a veterinary tranquilizer called xylazine, and that's been described as making overdoses more likely, making overdose rescues less likely, and creating the zombie appearance in inner cities and elsewhere where these drugs are used together. So fentanyl plus xylazine is a new trend, and that's been seen in fentanyl powder seized by the DEA, and about 30% of the powder they seize has this veterinary tranquilizer in it. The cartels distribute the drugs, and I'm not a current expert on it, but it's principally manufactured abroad, maybe assembled and distributed locally. There have been lots of suggestion about China-based precursor chemical companies and even incentives paid to those companies to produce. But the main shift, as I tried to emphasize, from growing, you can see if you ever been to South America and the Andes and see the fields and the cultivations, the DEA has numerous places where they can interdict, intercept, and cause rise in prices in the chain from growing to getting into the United States. For the synthetics, much, much less so. The prices are very cheap, and the consequences have been really extreme. All the methamphetamine in the United States, or virtually all of it, is manufactured now in Mexico, It's many times more potent and pure than drugs in the past. And, I think that's kind of how you have to look at what Musto called the American disease. We take a drug that occurs in nature. It may be have indigenous use, like cocaine, for example, which is used in the culture as a tea, used for workers operating at high altitudes in the Andes and working. There's a leaf chewing. But once it comes to the United States, we weren't even satisfied with Freud's cocaine hydrochloride for sniffing or injection. We had to invent crack so that we have injection without a needle, high doses, synthetic manufacturing, and ease of distribution to avoid interdiction.
Mark, it's a great overview. I just want to circle back and the mixture with the veterinarian medicine. That's what you're referencing in street parlance. That's referred to as tranq, TRANQ. Yeah.
Yeah, it's referred to as tranq, and I did a piece on it in June, called it the zombie drug, because that's when people looked and talked to people who were on this drug combination. They had more opioid effects per dose. That's the reason that people take it. So you buy X amount of opioid, you buy X amount of fentanyl. The xylazine makes it feel like it's lasting longer. The problem with the tranq dope is that from the outside, now I'm not talking about from the inside, from the outside, people say that the users resemble zombies, that they stare blankly into space, they have a very stiff and shuffling walk, and they have an overdose scenario that makes it very difficult for people to identify. And this has been a major city, principally, phenomenon in Pennsylvania, New York, and Ohio. But recently, there's a July 16th Millennial Health report. They call it a signals alert, where they're seeing now xylazine positive rates all across the United States, and now west of the Mississippi River as well, in urine tests and other. It's seen in emergency rooms. It just complicates overdose reversal. It's not a controlled drug, but it's kind of like the antihypertensive clonidine or catapres. So by itself, it would cause sedation, as it's used as a veterinary tranquilizer, but also low blood pressure. You add that to opioids, you get both, more sedation, more low blood pressure. And then the users in people, we see very deep wounds on their skin, like that's been described as having lots of dead tissue around their skin, independent of where they inject drugs. So just a dark spot will appear, and it just erodes. And in Philadelphia, I've spoken to doctors who send people for amputations as a result of this.
So I want to, and once again, every time, something gets introduced into the marketplace, it is rather amazing. And I think I mentioned in our first podcast, I had the honor of meeting you when I was a young prosecutor, and you came to the U.S. Attorney's Office in the Southern District to talk to a small group about something we had never heard of, but which was looming on the horizon, crack cocaine. And again, I know throughout your career you've seen the waves of various substances, and obviously cocaine and methamphetamine and heroin, and then, but now what is particularly interesting about fentanyl and just trying to understand it is what I'm hearing from you in describing what has happened to the marketplace. I'm drawn to what I'll refer to as almost a business model where we speak about various markets that have been disrupted. They've been disrupted by technology. They've been disrupted by technology that lowers the barriers of entry, that brings new things into the market, but basically displaces the status quo. And what I'm hearing from you about fentanyl is, number one, beyond the fact that it has flooded the markets and it is, a synthetic opioid, the barriers of entry for bringing it into the country have lowered. The ability to disrupt traditional law enforcement in the detection and the interdiction has occurred. The costs of production, the availability of the necessary chemicals and precursors is just, very different than having to cultivate a crop of cocaine or poppy seeds and etc. And that its broad availability and low cost has had a tremendously disruptive impact on the market of availability of addictive substances, but also a significant disruptive effect on the ability to enforce the laws and interdict the shipment of controlled substances. Is that, am I understanding what has occurred here, maybe in the context of a disruptive technology that really has had significant consequences in the marketplace?
Yes, you've said it much better than I have. I've really focused on just the idea that if you throw fentanyl into a marketplace that had previously 100 compulsive heroin users, over a short period of time you have 100 compulsive fentanyl users. If you throw methamphetamine in a cocaine marketplace, for the most part you displace cocaine. Exceptions might be in South Florida, let's say. But there's no doubt that that's underappreciated, just the cosmic effect. I've looked at, I'm a doctor and researcher, and I looked at what are the mistakes that researchers are making in trying to understand these differences. And, it's clear fentanyl is much more powerful, much more reinforcing than heroin, and that gets to your displacement model. But in addition, by targeting the brain's pleasure systems, and they both do that, fentanyl, by doing it at a much more intense rate, produces an effect that is probably much more toxic, and in the absence of fentanyl, produces a dysphoria, anhedonia that's much greater, with greater craving than for heroin. So it's disrupting the brain on both sides. And I tried to follow that up a little bit, looking at overdoses and what doctors commonly think about overdoses. It may be that naloxone or Narcan works great for morphine or heroin overdoses, but may not work as great for fentanyl overdoses. Maybe the fact that EMTs and others at the scene of an overdose are giving much higher doses is a reflection of the fact that people are just not waking up like they used to in the 1970s on an overdose. In addition, very recent data that you and I spoke about suggests that overdoses themselves leave telltale traces in the brain that show that we shouldn't consider them insignificant events. An overdose may be more like a concussion than, you need to drink more fluids. There are all kinds of mixed signals here. Think about it. If somebody, we resuscitate somebody with CPR, we check them for periods of time for brain recovery. And we know that periods without oxygen, the longer those periods are, the more brain damage or injury there is. But for the most part, when someone overdoses, they've overdosed many times before, and their medical records do not even include how many times, for how long, did they need a naloxone rescue, did that work right away. Many of the rescues done in the community, of course, do not include CPR or an ambu bag or oxygen. This is we have a certain number. Let's say there is 100,000 or more overdose deaths. For every death, there may be 6 to 15, nobody knows the exact number, of overdoses. Some of them are in the same person, but clearly we'll have to deal with that consequence in the future. But new brain imaging studies from the University of Pennsylvania, with the help of the National Institute on Drug Abuse director, show pretty clearly that after an overdose, there's changes that occur that if we were to treat people according to the neurological findings, we would have them at bed rest with diet and exercise, and take it seriously as a neurological event.
So what's particularly interesting about this, Mark, at least from all the reading I've been doing, is that people haven't, at least my reading, and you'll correct me, there's so much that makes the fentanyl crisis different. One is, I'll call it broadly the disruptive qualities, both in terms of the human costs, but also in terms of the ability to basically flood the market and to avoid interdiction and traditional law enforcement detection. I do know that in some ways there are similarities to prior crises. In fact, the issue of substance abuse, as you and I have spoken about, it's not just simply a medical issue and a mental health issue and we'll call it criminal enforcement, but it implicates geopolitical concerns in terms of where illicit drugs come from. We're hearing about it in the context of secure borders and immigration policy, etc. But what's particularly interesting about this, the last points that you've raised that, again, seem to make this very different, is you are saying that the consequences of the fentanyl crisis are actually even more severe and more profound and require studies. So it's not simply, reversing an overdose. There are long-term harms here that go far beyond what we have seen with other substances.
Yeah, I think when you're in the middle of a death crisis, it's reasonable to focus on death. New studies out there and new ways of looking at it. We have the problems caused by the drug adulteration, these kind of fake pills bought on the internet, and we have to save people's lives. We built a strategy around naloxone and overdose reversal, but we had the Healing Communities study, which identified 19 evidence-based recovery strategies, and I covered that in an article. And they did a full 5-year study that was reported recently in the New England Journal of Medicine, and it basically said that at the end of the day, after I don't know, maybe it's $350 million to do this study, picking model communities and then control communities. The communities that followed the advice and followed the evidence-based protocols didn't have any better survival than those that didn't follow them at all. So that doesn't mean to say that it was a waste of time and energy, because there was a difference over the 5 years of probably 500 deaths that were averted. We don't know if those particular people ultimately died of an overdose, but it's only one measure. So I just think we have even the strategy built around naloxone is challenged because fentanyl overdose deaths, I'll not get this exactly right, but I'll say over 20% of the fentanyl overdose deaths have naloxone in their body. They were given naloxone and it didn't save them. And part of the new understanding of the differences between heroin and fentanyl is that we're going to have to change some of our naloxone protocols, maybe to load up a larger amount of dose up front, maybe to include oxygenation, maybe to include the newer opioid antagonists that were approved, higher dose ones, and also nalmefene. We also have to spend more time and energy on prevention. That this again, you got me thinking like this because you were thinking about business model, but the opioid drug crisis has been going on, since the OxyContin pill crisis, so in a way has become evergreen. How can the top of the funnel keep producing like this? And the why hasn't it just stopped on its own? And it hasn't stopped because we're continuously recruiting new substance users. And even now, some of my colleagues working in child and adolescent psychiatry are reporting fentanyl overdoses in high school and adolescents increasing. So I'd say it's probably a good time to think again about prevention, think again about early intervention, think again about pre-addiction, and those are all missing in the strategy or underfunded. And then on the treatment side, to probably think like, why did we have methadone, and why do we have methadone restrictions? And now that you can get Suboxone in many places with through telemedicine, and there are some places that even have a virtual vending machine approach to this, with the notion being that if you're on medication-assisted treatments, you are not likely to overdose. Like, why wouldn't we have a system that supports long-term medication-assisted treatment, longer term than we currently have? Something like they did in the study in the New England Journal of Medicine, Healing Communities, the idea that doing a 5-year study like we do in oncology and seeing what works. But I think some of the methadone restrictions in the current era, especially with a trained addiction workforce, they're addiction medicine doctors. Many of these doctors are board certified in internal medicine and other primary care disciplines as well as addiction, that methadone may have value here in direct comparison. For example, if you took a person who recently overdosed and was rescued, and put half of them in methadone maintenance, hopefully for a long period of time, and half of them in Suboxone, most of the experts would think that twice as many people would persist on methadone as on Suboxone. And then what happens to a person when they drop out of medication-assisted treatment? Since these are not cures, it appears that the overdose rates are essentially the same as if they had no treatment. So it isn't like some insight-based treatment that changes them forever, or maybe even a psychedelic treatment that might change a person and revert them back. These aren't cures, they're accommodations. So the brain has made an accommodation to fentanyl. It's changed its opioid systems. And then without it, without exogenous opioids or without fentanyl, the brain does not think it's normal and drives the person toward additional use, relapse, slips, and so forth. And that gets into a question that's more suited for lawyers than for me, but in the harm reduction world, which is the world I've lived in developing new treatments for opioid users and people with other substance use disorders and long-term approaches. They've coined the phrase people who use drugs and admonished even people like me to not use the term addiction anymore. But people who use drugs does not capture the xylazine plus fentanyl user on the street in Philadelphia who does not appear to have free will.
So Mark, obviously what I'm hearing, and it's very interesting because various politicians, government leaders talk about the greatest threat to national security. They may talk about the borders, they may talk about cybersecurity, may talk about climate change, may talk about pandemic. Listening to you and looking as you've rightly put, the data always focuses on the deaths. It doesn't capture the lost lives. As you referenced, the zombie effect of some of this. Some of the personal stories that have come out, obviously they're, for political reasons, they're brought to the forefront at conventions with parents speaking, or certain newspapers will cover tragic stories in colleges. And you referenced the DEA's accurate campaign about one pill can kill. And very often young people who are taking this don't know they're taking fentanyl, no less being appreciative of the risk. But I just as I listen to you, I can't help but feel that you're articulating one of the great threats to national security, meaning that this crisis hasn't abated because there are new people who constantly come on stream, new consumers who are consuming this, and the statistics are not getting better. The trend is not a friend. And as I listen to you, I'm also hearing, in terms of your suggestions, that when it comes to what has occurred here, this wave of disruption because of the technology involved in the production of fentanyl and opioids and such, there really has to be a rethink around what we're doing and what we, and to apply some of the evidence-based knowledge that we now have. But there now has to be a fundamental rethink about addressing this, because otherwise things are not going to improve. And I very much seized on your nuanced term harm reduction as opposed to necessarily prevention or prosecution or whatever. But am I hearing you correctly about, and maybe contextualizing this correctly, that this really is an issue of national security impacting a broad swath of our population and obviously our many younger people, and the need to rethink how we approach this issue?
Yeah, there's no question that that's needed. It's sometimes the data looks better, but let's put it in context. Like the last CDC report said 108,000 people died of overdoses in 2023, and there were headlines about the first decrease since 2018. But it's a decrease that's probably less than 3% from record high levels of death. Like, what is an acceptable level of deaths? Like 110,000 or 112,000 in 2022, whatever. It's outrageous. My entire career in this field, I couldn't even imagine 3,000. I mean, it just doesn't. It seems like that's a bigger crisis than almost everything. The next is, we just are talking about deaths, but using drugs for 4 years is not like going to NYU or Harvard. It's not like that at all. It's the target for drugs of abuse. The target is the brain, and within the brain, the sub-targets, depending on the specificity of the drug, are the pleasure system. That's what getting high is all about. Target the pleasure system so that the feelings that you might get at a maximum euphoria might be produced by you artificially at will. Each time you do that, you get less of an effect, and then at some point that we don't understand, the cucumber becomes a pickle and has a hard time of making it back to a cucumber. That's for sure. That's kind of where the accommodations come in. So it isn't that we think methadone cures opioid use disorder, but it does allow a remission. It does decrease IV use. It does decrease craving, drug seeking, and allow people to go on with their lives, saying that they've acquired a chronic relapsing lifelong illness that they're controlling in this manner. That's we have large numbers of people like that in daily medication-assisted treatment in the United States now that we did not have before this crisis. Now, I'd point out the same thing is occurring with other drugs. We just heard that we had methamphetamine being increased in its potency, methamphetamine being smoked, methamphetamine being smoked with fentanyl that's now also being smoked, so that you have a speedball crisis, which by smoking obviates the need to use needles and gets maximum brain effects as if it's crack plus opioids. Many of the things that we've assumed about people with substance use disorders just are not true. A friend of mine who runs the Yale University's emergency room for drug emergencies told me that when they had a crisis at the New Haven Green that was covered in the newspapers, over 100 people overdosed at once, and all the physicians like him and other first responders rescued them with naloxone, that they wondered how this happened, And what happens is one person is knocked out like this and then sends tweets and messages and calls friends to say that there's really great and powerful dope at the New Haven Green, and people descend on the green. So while to somebody who doesn't use substances or doesn't have an opioid use disorder would think that's impossible, just the fact that the person overdosed and need to be rescued should dissuade other people from using. The opposite might actually happen in real life. So I'd say we need to rethink all aspects of the strategy, but not forget what's feeding the top of the funnel, which to me is early use, lack of prevention, lack of early identification and treatment when treatment would be pretty easy. We need to adopt the concept of pre-addiction, just like we have pre-diabetes, intervene and treat people before they've lost so much function that we can't get them to pre-addiction levels of function anymore. And then it is for the people who do continue on and we can't reach for one reason or another, poverty, homelessness, a combination of lack of education, and so forth. We have to have strategies related to overdose reversal, and then speed of new treatment initiation, and then some system to keep them in treatment long enough to help them rehabilitate.
So Mark, as always, great, and we'll be speaking again in about 2 weeks. I definitely want to follow up on the treatment, and you've touched upon the issue of a lack of free will that exists with substance use disorders. And also, I know you and I have discussed this. One of my personal frustrations is the lagging nature of government statistics around addiction and deaths. And I constantly see, statistics that are 2 years behind or 18 months behind. So maybe we can touch upon, how in the current environment where we have all these digital platforms, are we getting the necessary information? Are we getting the necessary data to even begin to think through and address these profound issues? But I can't thank you enough for spending time with us. Invaluable. And as I've said to the audience before, there are very few people, if any, who have your wealth of experience and perspective and have thought about these issues and continue to think about these issues in the profound ways that they deserve. So thanks for spending time with us, and I look forward to our next conversation.
Hey, thanks for having me. I always like it, and I especially like talking to you and your listeners.
Until next time, Mark. And keep writing. It's a public service.
Yeah, okay? I can't stop. I can't.
Seriously. It's a great public service, Mark.
All right. Thanks.
Take care.
Bye.
Thanks for listening to the RANE Insights podcast from RANE Network. Be sure to check out Dr. Mark Gold's full bio and host of written publications at psychologytoday.com. Want more RANE content? Find the RANE podcast series wherever you get your podcasts, or visit our website at ranenetwork.com. That's RANE network.com. Thanks for listening.